started. Okay, so we're gonna go ahead and get started. I know Ollie's on his way, but this is really our last meeting time for the semester. I feel like it's really flown by, right? So I did this at the end of this class just to kind of give a wrap up and bring together some different things we've talked about throughout the semester. So I have Kellie Simpson. She's the Director of Finance at Mountain State. She's going to kind of give us an overview of like what's going on in the healthcare environment in terms of finance and accounting, and hopefully, kind of bring everything we talked about together really nicely. And you'll see on your syllabus you have an assignment associated with her lecture today, so make sure you're aware of that. And without further ado, Kellie, I'll let you go ahead and let me grab my stuff out of the way. Clicker's right there, and whenever you're ready.
Well, since there's just a few people in here in this class, I'll introduce myself, and then maybe you all can introduce yourself and sort of give me a little bit of background information or sort of what your interests are and career, and so can maybe do some pointers on finance and stuff related to that. So about me, just career, interim AVP of Finance right now for Mountain States Health Alliance. My boss left a few months ago, so here I am. Worked in healthcare finance for about 6 years. That's all been at Mountain States. Before that, I worked in accounting for several years at King Pharmaceuticals. Did tax accounting at PricewaterhouseCoopers. Did not like accounting, so I moved over to the finance world. Graduated from ETSU in 2008 with a double major in finance and accounting. Got a certified public accounting license in 2010. Then did an online program for MBA International Business Focus from Tennessee Tech, and then a couple years ago got a certified healthcare financial professional license. So I'll open it up to you all.
Okay. My name is Ashley Dowrick, and I wanted to do something like with health in my life, but I also really like business aspect and managing, so that's why I chose the administrative part of public health, and I do like finance and accounting. I'm curious though, how come you like finance, not accounting? Like, how different are they?
They're the same and they're different. So finance is a little bit more hands-on, especially in healthcare. You're a lot more in operations. Accounting, you're doing a lot more journal entries, books. Finance is taking that information and running reports, providing that to executives. You're out meeting with people. So it's just a lot more hands-on.
Okay.
You learn, you get to know what's going on.
Okay.
Okay, I'm Teacher Bennett. I'm from Jamaica, graduated from ETSU with a first degree, family and consumer sciences with a concentration in merchandising. I don't like finances or accounting, but I'm winging it. I had to do it because I was in the certificate program for business administration. So that's what.
Yeah, me.
Okay. My name is Yemi. What do I say? I just like, I'm open to, for now, anything. Well, because I think I've learned a lot in this program. So I feel like I'm fitting. Maybe later, after a year or two, I'll be able to define which, both healthcare in general and medicine.
Well, we'll just have sort of an open forum, so you can just interrupt me whenever and ask any questions, and I'll try to answer to the best of my ability. I've put a lot of stuff in here about more like macroeconomics, and then a lot of information about payment systems, and a lot of that is changing very rapidly right now, and I think that's an area that if you're getting into healthcare, it's really important to have a good understanding, at least conceptually, of all the different things that are going on with payers and with Medicare, just to know a little bit.
I'm going to check something real
of click the microphone's blinking. I want to make sure it's picking you up to record you.
No, stop.
Okay. Sorry about that. That's okay. Okay.
Just want to make sure it was recorded. I don't know. It's really random. Okay.
So, current state of healthcare, I'll just put this slide on here. I thought this was pretty neat. Just sort of, there's a little bit of a disaggregation on the communication, and there's a lot of different things going on, but you have the physicians, insurance companies, your patients, and then your hospitals. So that's sort of all working together. So, from a finance perspective, over the past several years, we've seen commercial pricing growth that is no longer happening. So we're really approaching the limits of cost shifting. And what that means, if you look down at the bottom of this graph, on average in the healthcare industry, your hospitals lose money for every Medicare and Medicaid patient that they take in. So for every $1 that you spend treating a Medicare patient, you get 90 cents back. So typically what has always been done is that private payer, as you can see, for every $1 you spend, you get $1.34 back. So that private commercial contracts are really what you depend on to basically subsidize or help you cover the Medicare and the Medicaid patients that you lose money. So this is just another graph that sort of shows that on average payment relative to cost, you do not cover Medicare and Medicaid, but commercial has really helped cover that over the last several years. But we're continuing to shift closer to a single payer. So we're going to have more Medicare, more Medicaid as we continue, especially with our population trends, which I've got some information on that here in a little bit. But we're going to continue to see that Medicare population increase, whereas that commercial population is going to decrease. So what that means for healthcare administrators is that we have to figure out how we're going to cover and pay for that Medicare population with a dwindling commercial population to shift that cost to. This is a case mix, just some current 5-10 year projections, and these are Mountain States, but they're national averages as well. On the inpatient side, the projections are showing that we'll have more and more medical to surgical mix, and medical patients, you typically make more or make less on average than your surgery patients. So you've got some shifts in the kind of patients that you're treating and the revenue that you get from those. And then on the outpatient side, we're seeing a little bit less. More imaging is going to go more to an outpatient basis as we start looking more towards preventative health. So with all of those payer issues, trying to cover the costs on top of that, expenses continue. You see good? Is that better? Yeah. Okay. So for the healthcare industry, on average, your expenses continue to increase. So most of this, there's 3 main cost drivers. Market pressures of labor on average. A healthcare system's labor expense is about 50% of your total expense. So your labor force is huge for a hospital. Overhead expenses, as we continue to increase and wanting more electronic health records, more documentation, easier access to information, that's driving up the expense of your IT. And then we have an aging population. It's becoming more sick, and they're more complex and costly to care for. So this is something I went to a presentation a couple years ago, and I just found this really interesting. And the guy did a presentation on end-of-life care. So for all of Medicare spending, 32% of Medicare spending every year goes to chronically ill patients in the last 2 years of their life. Of that, we spend about $74 billion on the last year of someone's life and $40 billion on the last 6 months of someone's life. Adds up to $222 million a day. So I just found that very interesting. The guy's point was sort of that we don't really have good discussions in this country about end of life and what's the right thing to do, or we all sort of want to be Rambos and live as long as we can, even though that may not be the best decision for that person, or that may not be in their wishes. The family may not know that because we're not having those discussions.
So that amount of money is, like we said, just to keep them alive as long as possible, regardless of the quality of life they're going to have at the end.
So all of that, we never think about, when we're healthy, we never think about advanced directives and filling out information, and then, we get sick, and a lot of people, your families don't really know what to do or what your wishes really are. So just going to talk a few minutes about exchange plans, high deductible plans, and patient pay. So currently the economy is on the rise. Everybody's heard a lot about that. However, this is a graph that shows where that income is going. So as you can see, in the 50s, 60s, 70s, the income distribution was a lot more equitable. Now you can see pretty much all of this income growth that we're seeing in the economy is going towards the top 10 wealthiest people in the country. So our economy's on the rise, but it's all going to 10% of the population, while the other 90% of the population is not growing their income at all. So the economy's up, same thing, pay is not. So wages have stayed flat for the majority of individuals, a large majority of individuals in the country. So for a lot of people, that means the economy's still just really terrible from a personal financial situation. And also the population under 35, the income for the younger generation is much less than the higher generation.
I guess that's just because of inflation.
Yeah,
Everything's getting more expensive and my pay's not going up.
pay's not going up, and the income is all going to the rich, basically. Okay. And then, of course, we have rising costs. So this is the annual cost of an average family health coverage and how that's increased over the past 15 years. So you can see both the employer and the employee portion has gone up, and that puts strain on the entire economy as well, because that makes it, your out-of-pockets are higher, but it also puts a lot of increase on that employer to pay for this, which makes it harder for them to hire as many people with the cost going up per person to cover health insurance.
Sorry, so I have another question. You said it wasn't open for
Yeah.
So does that relate back to what you were talking about in your first couple of slides about how there's cost shifting from to the private private sector to compensate for the loss we're taking on Medicare, Medicaid?
Yeah,
Or
in
is that
some
what
ways
that
it
plays
does,
into?
because you always want to try to negotiate more with your commercial payers. So yes and no, I'd say it's probably in a bigger combination or scheme of information. I'm gonna skip that one. So this just shows our percent uninsured from 2013 to 2015, since the ACA has went live. So you can tell the darker shaded information is 15% or more uninsured, and the lighter it gets, the less uninsured population it is. So you can really see, especially in states that expanded Medicaid with the ACA, that they have a much lower percent of uninsured. So with that, a lot of commercial insurance, as well as the ACA, is based off of high deductible health plans. So just looking at an example of traditional insurance versus high deductible health plans, the impact on the patient, impact on the hospital as well. So traditionally, this is just an example of an MRI of the spine. So from a traditional insurance coverage, you wouldn't have a high deductible health plan. You would be responsible for some percent of that. So in this example, the gross charge is $3,252. Your insurance covers or has a contractual write-off of $2,016. So the expected payment for the hospital is $1,236. The insurance would cover $927 of that. The patient would pay $309. And what that is just 25% if you have a 25% copay for outpatient. Under a high deductible health plan, so in this first example, if you have a high deductible health plan where you have to cover the first $3,000 and you've met $1,400 of that, the total payment to the hospital would still be $1,236. But the patient would be responsible for 100% of that. And we'll see in the next slide that that doesn't always mean that they can afford to pay that. Under a high deductible health plan, once you've met that, you still typically have a copay that's smaller. So under that case, the hospital would still expect the same amount of payment. The patient out of pocket would be $124. Then the insurance would cover $1,112. So if we look at the impact of that on an income statement, you can sort of see here that with those high deductible health plans, the bad debt is going up. So if you look at 2012 to 2013, your bad debt went up from 2.44 to 2.99%. And the reason for this is because not all patients can pay their out-of-pocket. So a lot of that ends up getting charity subsidies to provide for that, or that ends up going to bad debt and collections. And this is just another example of how your ratios may change. So your self-pay is going to go down because you do have less uninsured patients, but that doesn't necessarily mean you're getting paid that much more. It may just, some of that is getting shifted to your charity and your bad debt. Anyone have any questions?
I promise nothing.
Yes.
After also. So, expanding Medicaid, for example, or increasing the number of insured population. Do we want to do that? I mean, like I remember last week when we had presentations, and anyway, bottom line was about close to 30% of the spending was unnecessary. So, for example, same like the economy is getting better, but people are not seeing it. Assume that Trump care passed, okay, and the ACA was okay, they repealed the ACA. The number of uninsured will increase like tremendous, right? But I don't think that will reflect on the medical services or anything, or people will notice, because, well, there's a lot of unjustified spending close to this, like the end of life. So, I mean, what do you think? Just your personal opinion about the number of spending or the amount of money spent on unnecessary services or end of life care? Is it like education thing before we actually make people really access services?
I think it's both. So when it comes to the ACA, you know, I think what really happened there is there was an underlying assumption that, you know, you're going to be able to take care of a sick population because you're going to have people that sign up that don't utilize services. That didn't end up happening. So you had a lot of sick, older people that didn't have insurance sign up for the ACA, but the younger population that probably would pay into the ACA but not utilize the services as much didn't sign up. So they weren't there to cover and sort of buffer paying for all those extra expenses. I think that when you're uninsured, from what I've seen with the ACA and looking at that population, a lot of people move from commercial insurance. So they were working for a small maybe a small company that offered insurance that decided not to offer insurance and let them maybe pay them more and let them sign up for the exchange. But the uninsured typically don't come into the hospital unless it's an emergency. So there is, I think, for the economy, some really benefit there to be able to provide more preventative services to people that maybe would prevent them from getting to some type of a disease or a state where it was a lot worse or could have been prevented, and it wasn't because they chose not to come into the hospital because they didn't have insurance. I think there was another question in there as well. Did that answer everything?
Oh, close.
Okay.
Mine was with the traditional versus high deductible, and I saw you had like two different figures for the high deductible.
Mhm.
Is it two different scenarios, the possibility of two different scenarios, or?
Yeah, so it's based off of if you've met your deductible or not. So if you've already met your deductible, you would have a smaller out of pocket, but that's assuming you've already utilized something within your year, your insurance coverage year that you already paid $3,000.
Oh, okay.
So in the future state, what we have to look forward to, and what you all have to look forward to, baby boomers. This is going to be a really big deal for us. As you can see, trends for the baby boomers begin retiring, and it is going to rapidly increase. Over the next 20 years, they're projecting that retirees will increase 60%. So what that means is these people are going to retire, they're going to go on Medicare, and then there's going to be less people, or maybe it will fall to us to have jobs that pay into Medicare to provide for those services. This is some local population trends for our market. So this is Southwest Virginia, Northeast Tennessee area. Looking at CDC mortality rates. So in this area, people 65 and older are expected to grow 3.6% from 2016 to 2021. Rapidly increasing in this area is the 75 and older population at 6.2% over that time frame. And of course, hopefully we'll have improvements. It's a population, but any improvements on mortality rate over that year is also going to increase the amount of people in that age bracket. And physician shortages. So the United States is a huge physician shortage. We're also coming upon anticipating nursing shortages in this market, as well as nationally. I heard the other day, our VP of HR was saying that a lot of companies have started recruiting nurses from different countries to come over.
So shortage in this area because they're going somewhere else for pay, or shortage because they're just leaving healthcare altogether? And this is just the hospital, like inpatient side,
Well,
right? Or
it's
is
all,
this
just physician and
practices and
nurse
everything?
shortage altogether.
General.
But, a lot of times you will see that a little bit more in hospitals than maybe nurses leaving certain areas because it's maybe a lot more difficult, or you have a varying work schedule. If you work at a physician office, maybe you work Monday through Friday, 8 to 5, you're off every weekend. Nurses in the hospital, they're on call, they work through 12s, they have to work so many weekends every month.
Well, I was thinking about the difficulties, maybe, and I don't know if you guys are seeing this more here or not, but I was just thinking about there for like 2 months straight, I would hear that commercial on the radio from Pikeville Medical Center.
Yeah.
And I mean, they were offering great money and stuff, but I just don't know how they could keep up with, like, is it just, I guess, harder to bring nurses and physicians into these smaller rural areas?
From what I've seen, a lot of hospitals are becoming a lot more competitive on that, or in anticipation of a nurse shortage, so there's just not enough nurses graduating to cover the amount of needs. So they project that's going to get a lot worse over the next couple of years. So a lot of hospitals are actively recruiting right now to try to get that filled so that they don't have that situation. So they're being very aggressive to try to offset that.
So if they're planning on bringing in foreigners or people from overseas, physicians or nurses, based on everything that's going on currently, do you think that's feasible or would be doable
Yeah,
with a lot
that's
of things that's been going on?
That's a good question. I want to say I have no idea how that's going to play out.
And I mean,
So-
probably not from people here wanting to recruit them, but from people overseas wanting to come in based on recent
Yeah.
changes.
Well, I think you have to think more globally too. So, we bring in foreign trained physicians to offset the pressures in the market, right? But if we're bringing a lot of foreign trained physicians here, what kind of systemic impact is that having globally in terms of poor countries where health outcomes are worse? Are we taking their physicians away? Now we're kind of derailing their health care services and their delivery. And is that like a domino effect? Are we seeing worse health outcomes because they don't have the providers there because we're bringing them in to help offset our? So I mean, I think it's kind of like a domino effect into things that are not intended to happen, but we're making it happen by default because we're trying to kind of spot fix and patch what's going on. I don't know. That's my personal opinion.
So payment restructure, and I'm going to talk a lot about this, but so from a payment standpoint, we're really going through a transition in healthcare right now. So we're sort of in that straddle. So the first curve is fee for service. Quality is not in consideration, or quality is not tied to your payments. You get paid for volume, so high utilization, the more you do, the more you get paid for. And the care is very fragmented. There's not a lot of communication across the whole healthcare spectrum. And then, so right now on the straddle, revenue drops, volume decreases, minimal reward for quality. And then on that outside of that, the second curve, you're really moving towards value payment, more of a continuity of care and systems. Providers are at risk for payment. IT becomes a big focus. You have really great IT systems so that physicians, SNF, hospitals, home health, all of those different care areas can communicate with each other, and then a much better physician alignment. And so this is just another little slide, but specific to Medicare, which is currently a fee-for-service payment, but they do plan on changing their fee-for-service to an alternate payment model. 90% of Medicare payments in 2018 will not be based on fee-for-service. And that sounds like a large amount, but when I say 90%, that may mean a very small portion of the payment has some type of a quality or some type of an incentive attached to it. So quality metrics, episode costs, and managing covered lives are going to start replacing more of that fee-for-service. And so this is just a little slide on the improvements that we've seen in reducing readmissions, and sort of that the projections are, we've had a lot of success over the past several years, but probably see that those readmission rates are going to slow down just because really have to make some headway in some other areas before we can make more improvements on that with that communication. And this is just another little slide that shows the patient care path, and just in the future we're going to start looking more where it's very segmented right now, that there's going to be more of an episode that'll be managed across the healthcare those providers are really communicating with each other a lot more to manage that episode. Anyone have any questions on that? Okay, so I'm going to go through just sort of how Medicare pays and some different payment methodologies, and a lot of these apply to commercial as well, but from a commercial payment perspective, each commercial payment or each contract is negotiated individually with that healthcare system or that hospital or the physician. So those can be very unique or not unique. It's all just dependent upon what that insurance company and healthcare provider agrees to. But Medicare shows all this. So this shows this year rate increases for Medicare in different settings. And this is average, just overall. So when Medicare is looking at, when they say they're going to increase payment by 0.95%, that can fall in a lot of different areas. What that means is that they're looking at their claims data overall for all Medicare patients, and then what happens within different buckets can vary greatly to that. So for inpatients, so for this year, for 2017, that starts in October 2016 for Medicare. The inpatient payment increase was 0.95%. And like I said, those can be in different areas. So the biggest increases were in psychiatry, OBGYN, and spine services. And here's a little breakdown of how they come out with that 0.95%. So they did a 2.7% increase for the market basket, for the overall U.S. market basket. The 0.8% two-midnight policy offset was a one-time occurrence that won't occur this year, but it was an offset to a rule that they had in place for several years previously. A decrease of 1.5% for the Taxpayer Relief Act, a 0.75% reduction, which is required by the ACA, and a 0.3% multi-factor productivity adjustment, which comes out to a base rate of a 0.95% increase. Now, that doesn't actually mean that your hospital or this is for inpatient, so it doesn't mean that your hospital is actually going to receive that. So you could receive anywhere along the spectrum of 7.75% decrease to 2.95% increase. And the reason for that is different metrics. So no quality reporting, or if you don't do meaningful use electronic health records, you get a decrease of 1.75%. The maximum value-based purchasing penalty is 2%. You can have the readmissions and then the hospital-acquired condition penalties. So those are 3 programs that Medicare does on quality metrics. That if you don't meet certain standards, you will get payment reductions each year. And then you have an upside. So there's no readmission or hack upside. So it's all penalties. Downside risk, no upside. But for value-based, you can have some upside on that. If your value-based scores are really good, then you can see some increases. And if you do quality reporting and meaningful use, then you can get up to 2.95%. And that is, as you can see, these are just some different service areas. So all of this always depends on the service mix that you have with the patient that you have in your population. So if you have a lot of one particular service over another, then you can also see very different changes than just a 0.95% increase, and that could go one way or the other. So there's an increase in penalties. So just some updates that they made. Cabbage, they added that to the readmission reduction program this year. And then there were 2 2 new measures added into the HAC program, and then they made a couple of changes to the value-based purchasing and then increased that penalty. The previous year it was a max of 1.75, and they increased that to up to a 2% penalty. This is the Impact Act, so this is just more on the outpatient side. They're trying to work more towards a site-neutral payment structure, which is more aligning in your ambulatory surgery, outpatient, and then physician office areas. So in the ambulatory setting, that ambulatory surgery centers increased 1.95%. Outpatient, so on an outpatient basis, and this is Medicare has different programs and completely different payment structures for each major setting. So you get paid differently for inpatients versus outpatients if you're classified as an ambulatory surgery center or you're in a physician office. So for an outpatient, they had again the 2.7% market basket, and then the 0.75% decrease required by the ACA, and 0.3% productivity adjustment, which was a 1.65% increase overall. So on the inpatient side, hospitals get paid by what's called a DRG. It's a diagnosis-related group. What that means is you have all these codes, all these diagnoses, and they basically look at what was wrong with the patient and what services that you provided, and then they pay you based off of that. It's a single payment rate, so it doesn't matter how much you had to provide to that patient, you still get paid the same. So there are a little bit of codes to that. They call it CC or MCC, so complications or comorbidities, or major complications or comorbidities, which is all really based on your coding. But you could have 2 patients that would qualify for the same DRG, get the same payment, but you may spend twice as much to cover for one or to provide the care that's needed for one than the other patient, but you would still get paid the same. On the outpatient side, even though we're still fee-for-service, they're really starting to shift more towards that direction a little bit more each year. So Medicare has what they call status indicators. And so here this shows the status indicators, and each one of those signifies a different payment methodology. So J1 is a big one. They just started that a couple of years ago. And what that means is it's basically like a mini DRG. So if you have a code or a service that you provided on an outpatient setting that's considered a J1 status indicator, then you get paid a single payment regardless of the services that you provided. So if you had to say 1 CT scan or 10 CT scans, for those services you still get paid the same. And they're starting to shift a lot of surgeries over to that. And then like your T is another big area where a lot of surgeries hit, where if you have 1 surgery, you get paid 100%. If they do 2 surgeries and during that same service, then you would get paid 100% for the first and then 50% for the second. So they would discount your payment rate. So this is just some examples of the impact of imaging services due to the APC and the status indicator changes. So you can see within each of these, they can change very dramatically year to year, which can really impact. Yes, it's a 1.65% increase overall, but for your hospital system, it could be completely different. So it's really important to have a good understanding of that and be able to analyze that every year to know sort of what to expect and what services you may end up taking a hit on, or you may have payment increases. So like MRI of the brain, with or without and with that payment rate last year was $2,718, and they changed that to $264. So for each one of those that are done, we get paid $2,450 less. On top of that, if that MRI of the brain is done with one of those J1 procedures, we wouldn't get paid anything.
And you may have covered this and I may have just missed it, but like what causes such a dramatic change from year to year? Like why one year did they decide that it's going to be it's going to be worth $2,700, and the next year like, oh well, it's like $200 this year.
So they have this whole big method that I'm most certainly not an expert in. But they have a method that they take all of their claims data each year and then information that hospitals provide on their cost report. You basically have to fill a cost report out for all to send to Medicare that for all your patients, these are the services that you provided and these were the costs for those. So they look at those and then
Just like gross charge, like this is gross charge, what it costs us to give the patient that treatment or whatever, and they just kind of take
your actual costs.
Yeah.
So you classify your costs into these different areas. And then, they just make changes. And then that may be one, maybe that. They'll also look and say maybe the cost of that service has changed up or down. So has something changed in the way that care is provided that that particular service is more costly or less costly? So new technology has come out on the market or something like that, and they would take those things into consideration as well. If it costs you less, then they are certainly going to decide to pay you less.
So, in terms of like your job and your department, like how hard is it or how stressful is it on your financial analysts and default the managers of these departments to like keep up with these drastic changes and like, because how can you plan in the long term when they have like such drastic changes like this? I mean, how stressful, I guess, is it, or I don't know, like how is it to deal in that type of environment where things just change just like that in terms of cost? Because I mean, that could be a pretty significant hit to your hospital if you're planning on bringing in, $2,700 per MRI of the brain, and then all of a sudden you're getting $264.
It's a challenge. You just really have to keep on top of it and just expect. I mean, it's difficult because sometimes you don't even know. I mean, they'll send out proposed rules and then you get the final rule and it can be completely different. So you may not know until up to a month before you start getting this payment, and then it takes you that long to calculate it. So by the time you calculate and go through all of these, you're already getting that payment, or you're getting close to getting that payment.
So this may be reaching a little, but and this may be kind of beyond what you're knowledgeable of, but what kind of effects does this kind of feed down into provider practices or like clinical practices? Is there communication between finance and like physicians on, okay, I know physician, you prescribe a lot of, or you order a lot of MRIs of the brain. Well, here's how the rates are changing, so we need to make sure that every MRI is absolutely medically necessary. You know what I mean? Like, how does that relationship work in terms of here's what we're getting paid, and now here's how it's affecting clinical practice?
I really think the industry as a whole is just now starting to get there. I mean, this, 5 years ago, maybe not 5 years ago, 10 years ago, there were these considerations weren't in existence. There was payment increases, and there wasn't really, you didn't really have to deal with that. You didn't have to work with that. So I think you're really just now starting to see that. So first, I think that hospitals went to the low hanging fruit and got all the cost out that you can get out without. That's easy, So I think it's just now really starting to see over the past couple of years that care coordination and that, which is exactly what the intent was. So I don't know. I mean, I don't know how much I can answer that.
Yeah, like I
question
said,
right now,
maybe
'cause I
a
think
little
that's
slow.
really still developing. I mean, it's
It definitely
happening,
kinda
but
gives that-
not as much as it's going to over the next few years. So those are things that in the industry we really have to start developing and working towards.
Like I said, it definitely starts pushing you more towards whether you go willingly or kicking and screaming towards coordination of care, right? Because if we just continue to think of a hospital as a business, I mean, these are things we have to do, or activities we have to do as a business to stay viable out in the environment, right?
I think it's insurance thing. Like, if the patient has really good insurance, he just, I mean, the physician does not think hard, he has headache, MRI will give you the diagnosis. But if he has like not a very good insurance or high copayment or something, think hard, but like, okay, so let me try to do this as a blood test first. So, but you don't go the extra mile if the patient is already has a very strong insurance that will pay. Like, ultimately, the hospital will suffer and the industry, but in the short term, not you, not the patient.
Yeah, and I think with the shift to more high deductible health plans, people are starting to shop around a lot on their own. Because I think what I feel, and this is personal opinion, but what I feel hasn't really happened in the industry yet is some responsibility for the consumer. So our country is we want it. We think we want it. We want it. If we don't know, we want it. And we just want everything and we want it now. And there's not really a lot, we need to start having more discussions as a country. I think that, hey, maybe you should get out and exercise more or eat an apple instead of a candy bar, and we're not going to have as many of these problems.
Well, that's just like, I don't remember.
That was what you said.
Yeah, I don't remember if I gave it this thought, but, my husband worked in the ER for several years, and it'd just be, he'd have a patient come in with CHF or some cardiovascular disease, and literally while they're sitting in the bed, Pizza Plus would walk in with a pizza for the patient, or they would get discharged and then they would go straight outside and smoke, or they would head on down to McDonald's and get their quarter pounder of cheese.
Yeah.
Yeah.
And we're all responsible for that. And it's not just you. I mean, we have to, I think, start thinking about, it's all of us. I mean, our entire country has to pay. If you work, you pay into Medicare. So we have to start having those discussions that, that impacts how much money that we all have to share. So.
There would be people in the hospital that would come in for overdoses, and they would have their heroin dealers come while they're there for an overdose and inject their drugs into their IVs. And then the drug dealers would get in fights with the fighters in the hallway. It was
Where is that?
at the hospital I worked at over the summer.
Serious?
And then they're treating them for their next overdose or whatever. Yeah.
I love this story.
Sorry. Didn't mean to damper the.
I don't know what to
mood.
say after that.
But I'm saying that that's something that the hospital is going to end up having to probably take a loss on.
Maybe it's population health, as you said last time, approach to.
Well, it's like what is really going to work? I believe the politics is not really making the parties to really come together and find a solution until I don't think we're gonna, because like I saw like a report, when was it, last week, published in New York Times, that just show like how drug overdose really is like the epidemic, something that have to get, it kills more than anything, more than any other thing. Now, it's like number one priority. So, and at this stage, people are still figuring out. The CDC published a report about, they still don't know like which is the best way yet to.
There's a lot of belief that needs to go down, and it's responsibility on a whole. But I think they have to start with them at a young age. Even in terms with the whole being active type things. Start from a younger age. Schools probably where they have some sort of sports day, which I think would kind of tap into a lot of the issues. Yeah, including even the drugs, because they have something else to do. A lot of the things, the extracurricular activities that people do, it's because they don't have much to do. So it's all about the media, the gaming, all of those things instead of out there socializing and getting active. So I believe responsibility and it has to start.
At the same time, it still goes to like freedom. People feel like I can do whatever I want to do. For example, people now they are pulling out like of vaccination. I don't want my son, I don't want my daughter to get that. Measles is coming back. Like some other things. Like, I just feel I can do whatever I want to do. It doesn't make any sense.
Yeah, they have too much choice.
That fine line between luxury and right, like healthcare at certain point it's right, after that it's luxury. Like if you want people to drive slowly, don't give them airbags, put a shovel behind them. Seriously, like to avoid it's right, and then like
need
this
to be
game is they have
consequences.
this luxury now,
Yeah, they
There's
give them
no
too much
consequences.
choice. Yes.
They do what they want with no consequences.
Yeah, that was why I supported what you said last week. That you don't need to, you don't need to pray for people that is they're gonna like go there and mess up their lives, and they end up spending all the money, and people that you are not spending anything. You wake up early to exercise because you don't want to be in the same situation. You pay the same premium as those people, and they ended up they do whatever they want to do, and they spend most of the money. And it doesn't really it's
Too much freedom.
And it's like the
Sorry, when I down
freedom of
class a little
speech.
bit.
We kind of diverted.
Yeah.
kind
of
of
work
a
back
serious
its way in, but
discussion.
yeah.
I think the people in healthcare have, it's a serious. Even I know that it's not easy for the policymakers as well, because they just don't know. They're trying to compromise. Personally for me, sometimes when I read something about policy healthcare, I don't know why I get concerned that much. I get this like palpitation. I feel I should, I should get an idea, and, it's like that for everyone. People don't, they can't just figure it out. It's quite complicated.
Almost like an unsolvable problem. Sorry.
So this just shows the trend with Medicare on outpatient and expanding packaging. So these are all conditional packaging, or you don't get paid at all. So status indicator and those are things that they want you to report that you're providing Medicare patients, but you don't get paid on it. And then the Q1, Q2, and Q4, those are all conditional. So sometimes you get paid for those and sometimes you don't, according to what combination of other services that you provided. So each year they continue to add those.
So, and I guess SIN is the things you do get reimbursed on.
That no, those are things you don't get
Oh,
reimbursed.
don't. Okay,
So this is just the ones that are
Reserves.
packaged.
Okay.
So those are packaged all the time. You never get paid for them. So this is just an example here of just the J1 packaging that we talked about was a single case rate, and how that is continuing to increase. So those started in 2015, and then they're increasing the quantity of those every year. And this is a little bit more detail about those J1, and they're called comprehensive APCs. They're paid like a mini DRG, so almost just like in an inpatient setting. So they make those payment rates based off of the average of what's billed on those claims, and that's how Medicare sets the rate. So that can hurt you or help you according to your utilization on those services compared to the national. So if you have really, really high utilization of services, so your hospital that you provide the surgery on average, you have $500 of drugs or $1,000 cost of CT or imaging services versus a hospital has lower utilization, you may end up actually netting a little bit more than they would. So it's all going back to that, just another way to put a little bit more pressure on those high utilizers. So if you're analyzing this and you see that you're losing money, then you know you can sort of extrapolate that on average, your services or your costs must be higher than the national. And then if you see that you may have a pickup or a net gain from a financial perspective, your utilization is probably a little bit lower than the national average. So it's just putting more pressure on that. And that's just another slide that just sort of shows how they're continuing to package more. This is just a list. Just wanted to talk about this a little bit. So they removed 9 codes. They have each year they have what's called an inpatient only list. So services that you are only allowed to provide in an inpatient setting. 9 codes came off this year. 9 were added. So that means that these 9 services can now be offered in an outpatient setting. Not always, but the majority of the time, your contribution margin is higher on inpatient than outpatient. So what that means is if you choose to do this in an outpatient setting, you may also have more competition. This can be done in maybe an ambulatory surgery setting or some different setting, but that's usually maybe something has happened with those that they feel can be done on an outpatient setting that the patient doesn't need to stay there. A big one right now that's come up is the proposal to remove hips and knees. So that's a big one, is providing hips and knees on an outpatient setting. Hip and knee replacement. So on the physician side, sort of the same thing that we had went through. The total was a 0.24% increase for physician services, and a lot of those, as you can see, provided on different services. So some went up and some went down. Okay, so I want to talk a little bit about macro. So this is a new payment system that CMS is coming out with next year on the physician side. And it's going to end a sustainable growth rate, which is the formula that they use right now to pay physicians, and is going to establish MIPS and AMPS. And I don't know if you all have noticed, but in healthcare, we like to have acronyms for everything. So that's a big learning curve. And sometimes acronyms can be used for different things too. So lots of fun. So yeah, this is going to replace the payment system that they have now. So you can see from 2016 to 19, there's sort of that guaranteed 0.5%. 2020 to 25, that will be 0%, and that's going to shift into these MIPS and the APM bonuses based off of what track the physician chooses to go in. So it's going to go much more into a merit-based program. So the final rule, as you can see, the way that this is operationalized, there's a little bit more of an impact for larger clinician groups than there are small practices. So it's still, if you look at this on a scale, this is going to increase payments a little bit, but it still does not keep up with just our average CPI, and then the red is actually the operating costs per physician FTE. So the physician costs are continuing to increase at a much, much higher rate than payments are increasing.
Why is that?
So typically, what we've seen over the past few years is that payment rates have been lower than just the average. Market basket increases for different reasons, but there have been different federal regulations and acts that have come in that require payment reductions like the ACA, and they just don't keep up with cost inflators. So these are the cost weighting. So in 2019, 20, and 21, the MIPS program and how much is going to be paid based off of different metrics. So the first year, a lot of that's going to be based off of quality improvement activities and advancing care information. And then in 2020, they're actually going to introduce a cost metric in there that will have a much greater weight of the total payment incentive for 2021. So quality will be 60%, and what they're going to do sort of to transition into this new physician payment model is that at first it's going to be if you just report these, you will get credit for it, and then it'll start going into actually your performance. So 60% will be based off of quality. Resource use or the cost will be 0% the first year, and then it will be based, have an impact of 10% in 2020. And advancing care information, 25%, and the clinical practice improvements, 15%. And these just show just some different metrics that they have to do in order to get these scores. So it's going to be a lot of reporting. I think that's going to be difficult for small practices that maybe don't have practice administrators. They don't have people that manage all of this stuff for them versus that bigger practice that probably has practice administrators or managers that are doing a lot of the data mining and billing and collecting the information. So like I said, it's a transitional scoring policy. So at first, you don't have an impact. You just have to report it. If you don't report it, you get a 4% decrease. And then this is the timeline implementation. So each year, this bucket of metrics is going to get a little bit bigger of their payment total. So physicians can earn up to 10% in the outer years, but then the offset of that is you can also lose 10%. So it's downside risk as well. So there's another program within this called alternative payment models. They're really encouraging physicians to go towards this model, and they're offering a 5% lump sum bonus to try to get physicians to go on this quality track. And there's just a couple different options based off of the risk structure that you want to participate in and what kind of practice you are. You may qualify for different ones. So this is just some of the options right now. Oncology care model track, Medicare shared savings. So some different care models. There's one for primary care. So like I said, based off of what track you want to go in and then what your practice is, you have some different options.
So I got a question.
So how much of your time and resources is put into just one, understanding, and two, keeping up with all these different programs, all the changes from the governmental side, the private insurance? Like, how much of your time and resources? Because this seems like it's a full-time job in and of itself to just, one, understand
You know, if you want to
Yeah.
speak from, you know, in particular to your department or just kind of more globally, but what's it kind of like from that end to just keep up with the pace of even understanding what they're talking about?
Well, in the United States, we've got a little bit, call it disaggregated. I think it's pretty normal for hospitals, but we have a managed care department that does nothing but commercial contracts and negotiations. So you think this is just Medicare. So all your commercial contracts, you are negotiating if you're going to have increases, if those are going to be fixed, or if they're going to be tied to quality and how. So they're doing all of that, and they work very closely with our quality department on those. So there's a whole team. They have, three people that really look at those all the time, and they're in there negotiating with the commercial payers, and then making sure, running an analysis to make sure how's that going to net, how are we going to net out with this, and then going back to the payer and doing more negotiations. So they also look at our 10 care. So we're going to go over bundle payments here in a few minutes, and 10 care has mandatory bundle payments now. So they're looking at that. And then we participate in an ACO that's part of the Medicare Shared Savings Program. So we have a couple team members that work on that. And then we have a reimbursement department who looks at nothing but Medicare. So they look a lot at the inpatient, and then the finance department always does the outpatient reimbursement analysis for Medicare. And then we're also working on a value-based scorecard metric. So we're starting to develop metrics looking at all of our contracts and what the financial incentive is for every single quality metric, how those go along the spectrum to see what our biggest opportunity is. So, you know, how many contracts do we have that have a readmission penalty? And if we were to operationalize something to offset that, then what would our financial opportunity be under these different scenarios? And somebody who spends about 50 to 60% of his time all the time working just on looking at value-based metrics.
So it seems like just by the nature of the size of Mountain States, you guys have a little bit of an advantage because you're a large organization. But maybe more in your opinion, how do smaller practices and organizations keep up with, you know, their limited amount of resources? And, you know, I think especially in the rural area, you know, you have your smaller rural practices. And, I mean, how do they keep pace with this?
I don't think that they do. I mean,
Yeah.
this is one of the many reasons why you see in the healthcare industry right now there's significant mergers and acquisitions. So there's very few independent hospitals anymore. I mean, we don't have any in our region anymore.
Just a matter of survival kind of at this point.
So this is just a timeline on the payment adjustments based off of the fee schedule. So again, the fee schedule, they're not going to have any increases for physicians, and it's all going to be based off of these quality metrics, the MIPS, or if they choose to participate in the APM, they'll get the max adjustment for the MIPS and the additional bonus. How familiar are you all with value-based purchasing? The times?
You got 2:15.
Okay, yeah, so I have plenty of time. I used to leave at 3:30, but. Okay, so value-based purchasing, this is a part of that inpatient payment rate. So it's housed inside of their our quality department keeps up with this. So this information from quality, they do a great job with it. But this is the definition from CMS on what value-based program is. So the intention is to reward healthcare providers with incentive payments for the quality of care they give to people with Medicare. So it's better care for individuals, better health for populations, and lower cost. Medicare began this program in October of 2012. And all of this data is publicly available on So you can see all the Medicare quality metrics for every hospital. So this is a great place to go shop. Like if you plan on having a procedure or something that you want to schedule, you can go out there and look at this information and compare what specific metrics are for each hospital. It's just for Medicare population, but it's also just really good information to look at. And then the performance periods are based off of calendar year. So a percent of our inpatient-based operating payments are on risk based off of these metrics. And then you can see each year those have continued to increase a little bit more. So that percent, so we're now at 2% of our total inpatient payment rate is based off of the value-based purchasing program. And so you can just see this is a quick comparison of 16 to 17 and just the measures that changed in that. So patient experience is 25%, safety is 20%, efficiency 25%, and then clinical care is 30%, with 25% of that being based on outcomes, and then 5% of that based on your process. Skip that, but if you want to look at that, that goes through each of the metrics that are in those. This is the value-based purchasing 2018, and then there's 2019. So that goes into detail of what makes up each one of those. So you can earn 2 scores on your measures, achievement or improvement, and then the final score is awarded based off of the higher of those 2 scores. So an achievement point are based off of comparing the hospital results with the median of all hospitals and the benchmark. So the median is your 50th percentile, and then the benchmark is the 95th percentile. So if the performance is at or above the benchmark, then you earn 10 achievement points. And if it's below the median, then you earn 0 achievement points. And if you fall between the median and the benchmark, you earn between 1 to 9 achievement points based off of that range. For the improvement points, those are earned by comparing hospitals' results to your same hospital during the baseline period. So this is you comparing to yourself. So if you're at above the benchmark, then you earn 9 improvement points. If you're below the baseline period results, which means that your quality in that particular area has gotten worse, then you earn 0 improvement reports and improvement points. And if you fall between your baseline or your benchmark, then you earn between 0 to 9. So the difference is comparing to the national versus comparing to yourself. And this is just a little thing that goes sort of it does go back to the actual care that's being provided. So I know a lot of times quality, finance, and a lot of those areas, it's a lot of data, but that data is based off of the actual care that was documented, and then your coding, which drives your insurance claims to get your data, and then you're aggregating and reporting that data, but it all does source back to the care. So another payment program, and these are all just Medicare payment programs. So you can see there's a lot of different things going on. So bundle payment for care improvements. This is quite complex financially, but the basic mechanics, so we'll go through the basic program outline, the pricing and risk track methodology, and then gain sharing overview. So this is just a detail of one model. So what this payment does is it really tries to bundle payments. You get a single payment based off of the entire episode of care. So for the Model 2, it's a 90-day bundle starting with the inpatient stay. So what that means is when the patient arrives at the hospital and has this certain condition, that is when this time starts. And what they call that the quarterback. And like for 10 Care, mentioned earlier that they have a lot of mandatory bundled payments. A lot of those for 10 Care, the physician is the quarterback. So diabetes is one. Maybe a person comes in with diabetes into the physician setting, and that would be the quarterback. So that would be when sort of that time clock started on the full bundle payment. So you still get your normal fee-for-service payment. So the patient comes into the hospital, you still get paid. They go to the physician, they're still getting paid. But they are trying to align the providers to manage the care and reduce Medicare costs by changing the utilization of post-acute services. So what that means is they're trying to get the physician, the hospital, and your post-acute, your SNF, your home health to align your care for that patient in a more efficient manner.
It's okay. I do it all the time. Don't worry about it.
The goal being that you're going to reduce the cost that Medicare has to pay you, but because you're getting paid less, they're going to share that with you. So you save them money and they're going to give some of that back to you. And so all of that, anything that you save Medicare goes back into your gain sharing dollars. So for this Model 2, the 2% reduction in episode payment is kept by Medicare. So that's their baseline. Here's your baseline. You have to get a 2% cut, and then we start the gain sharing. This was, when this first started, you had to start at least one bundle by January 1, 2014. These were voluntary. We did several of these. They just went live with hips and knees, the total hip and total knee replacement, as mandatory for certain hospitals that had a threshold of quantity of patients that came in with that. And these are, you can enroll quarterly. Claims data is sent monthly, but it's sent very past due. And then they do a quarterly reconciliation. So in this program, you're compared against yourself. So the bundle target payment is based off of your data. At this time period, the average was, your baseline was 2010 through 2012. And all you have to do is get better than yourself. That sounds a lot easier than it really is. And then you contract with providers that have quality and performance metrics. So approved waivers. This is one with SNF, a 3-day hospital stay requirement. With certain DRGs, so hips and knees are one that they had a 3-day mandatory requirement. If they didn't stay in the hospital for 3 days, you got a reduced reimbursement. So in the hip and knee program, that was waived, and you could release the patient in less than 3 days from the hospital if you sent them to a SNF that was rated 3 stars. And the Medicare Shared Savings Program, which is another program that they do, get their portion of gain sharing on this patient population before the hospital and the physician gets their share. So how this works, and basically the intent is, if you look at a current 90-day episode, so a patient comes in to have, say, hips and knees is one, or heart failure. They come in, you have your utilization of services. So if your bundle payment average per episode is $15,354. They're going to take a 2% discount, and anything that you get better than that 2%, you get to share in the gains. But this is the full 90 days after they're discharged. So how many times they're going into the physician, how many times they're getting readmitted, how many times are they utilizing outpatient services, SNF, home health, or anything else, long-term or rehab. So your goal is to work with these other care settings to communicate better, get them in the correct setting, and reduce the overall utilization to save Medicare money. And when you do, you get to share in that. So in this example, if your original baseline was that Medicare spent approximately $15,354 on this patient, your target's going to be $15,047, and if you were to get down to $13,720, you would get to gain share in that. So Medicare would keep the first 2%. The rest of that would be in a gain sharing pool. So they have different risk methodologies, and I'm not going to get into this too much, but they basically do what's called a Windsorization calculation. So based off of what risk track you're in, you may go to the 99th, the 95th, or the 75th percentile on the risk tracks, but you take on more risk. So the bigger the risk, the bigger your potential gains, but the harder it is to get to your goal. So this is just the process model, the hospital-specific experience, and then they apply the Windsorization. And then if you don't have enough volume to meet certain thresholds, then they would do another state-level empirical base, and then that would set your target price. And so this is just showing random variation based off of that 95th and the 75th percentile. So there's just more risk in each of those. And then this is the same thing, but in a bell curve. So as you can see, the outlier is here. So you're responsible for that difference. So when they first, so just high level findings, the average episode, there's gains and losses. So you're going at risk with these. If you choose to do this, it's something that you have to know that you have really great physicians. You have maybe a SNF or a home health that wants to work with you. That physician really wants to improve that population and work with the hospital, and you're all working together, because if you don't reduce the cost, then you're at risk to pay Medicare back. So if you say, I can reduce 2%, but you actually increase by 5%, then you have to pay them for that. So again, selecting your high degree of protection, which is the Windsorization, the model that's 75, 5% reduces your risk, but it reduces your potential gain as well. So then the gain sharing, there are a couple of different tiers, but the tier 2, the 65% hospital, and then 35% would be go back to the post-acute providers or the physicians, or the physicians can gain up to 50% of their total fee-for-service per episode. So these are just different options. So with each one of these, they have specific bundled payments based off of different DRGs, and within each of those, there's a multitude of different risk options and gain sharing options that you can decide on. You really just have to model each one of those out and sort of have a game plan for how you want to operationalize that, to know sort of what you might want to go with and which one's going to be the best option for you. And this is just a distribution example. So if you were to have a $2,000 gain sharing bonus, the physician would get 35% of that. The facility would get 65%. The reason is you're the quarterback. You're considered the initiator. So in other bundle payments, where the quarterback may be the physician, the gain sharing distribution can be different. So this just sort of goes through the primary care, the hospitalist, and the surgeon would get allocated a percent of that $700 that they would end up getting back. So that's all different Medicare payment models. I didn't get into ACOs or the Shared Savings Program, which is a different model altogether. Mountain States does have ISHN, and Medicare has we do participate in the Medicare Shared Savings Program, which is they have an accountable care organization where they're really another way to try to manage your population, and they have care coordinators that work with that population that's in ACO to make sure that they get the care they need when they need it, that they're using accurate utilization and trying to reduce. And Medicare does the same things in those ACOs is that if you save them, there's certain targets, and once you reach that target, you get to gain share with them. So the more that you save Medicare, the more that they will give you back. Are you all just having a lot of fun right now?
Taking notes, trying to keep up.
I think it's just the amount of information. It's just so. I just honestly don't know how you guys keep up with it. In all honesty, right? I mean, I'm just sitting here thinking, there's more programs out there than what you even talked about. How do you know? It really makes me think, like, how does a hospital survive? In all honesty, how do you keep turning a profit and stay profitable, or to the point where you can still manage, the activities of business to stay viable out there to continue providing care? It's just.
Well, I'm going to switch gears now and talk about some of the functions within a hospital. And I started with revenue cycle because revenue cycle really drives a lot of your other financial information. So they're the forefront, of who the patient sees. And a lot of the information they're gathering and collecting, a lot of the information that your data is driven off of. So this is a good slide that sort of shows everything that feeds into the revenue cycle, which is a lot, what they do, and then what also feeds into that. So what's the revenue cycle? So there's some main areas that they cover, but they're really right there. If you come into the hospital, that's who you are talking to. So access, which is known as admitting or registration, for the individuals that check you in when you come into the hospital. They also, if you have maybe a scheduled procedure, they're the ones who are scheduling you for the procedure. They're checking your insurance and verifying your insurance. They're giving you quotes on what your patient responsibility may be. They're collecting that. So then we go over to case management, which is got here pre-authorization activities, but case management, and then patient care management. So those are people who are maybe working up. You're in the hospital. They're doing a working DRG. What is this patient going to come out to from a coding perspective? What do we need? Really doing a lot of care coordination with that. Health information management, medical records, so they're scanning your medical records and making sure all of the documentation is there, and coding is taking all of that medical information and extrapolating how to code. So every single one of those diagnosis codes that your physician's putting in, what does that add up to, and then how does that end up maybe coding up to the DRG that you bill insurance for. And patient financial services, so the billing office, getting the bill out the door, getting that back in. Once that gets processed from your insurance, they're sending maybe potentially you a bill if you owe any out of pocket, doing collection, bad debt, a lot of those. And they're also doing like denials. So maybe your insurance company denied, they may be reprocessing that claim or filing it, maybe that we don't agree with the denial and believe we should get payment for that service that was provided. So this is the billing system process, and it sort of shows all the information that they have to collect: patient demographics, to verify insurance, so the charge master, so every service that you're providing, either automatically or maybe the nurse or somebody is putting in the services that they're providing, so that you're getting charged for everything. The patient's getting charged for everything that they're using. Then that's going through coding to go into the billing system, which then feeds from an accounting perspective, your general ledger, your UBO 40 or 1500, which is what is your claim. So that claim is going out to the insurance company. And then it's going into payer-specific edits. So it can get very complicated. Different payers may require you to code things differently. So if you come in and somebody else comes in, they have two different insurances, but you have the exact same service, does not mean that we get to bill you the same way. So we have to do edits and do scrubs and make sure that the claim is in that exact manner that each and every payer may want that claim to be in. Making sure that that is a clean claim and then sending it out and getting paid back for it. So this is just a good example of the process of an inpatient account. So the bed request, and then it goes into pre-admission. So they're verifying your insurance. You get admitted, you're in-house, and then you get discharged. So once you get discharged, you don't immediately get billed. That goes in through coding. And then you get billed. The bill is submitted, and then they're doing an account follow-up on that until the agreement is made between the hospital and the insurance company that they both feel that everything was paid that should be paid and the amount that they thought it would be paid. And then that process may start over again if there's an out-of-pocket that has to go into the patient account resolution, and then the money is coming in with each of these. So we sort of went through this. This is just the key contributors, but these are the different people or different departments that make that up. And then it's just important to note that all that information they're collecting, is driving data that compliance finance everybody uses. So they're collecting information that you can do research on, or are you male or are you female? What county are you from? Things that you can do a lot of data mining with. So it's really important for them to get that right. What physician had the order, or what physician referred you, if you were maybe referred to a specialist by your primary care. So just imagine you can do lots of data mining on that. Any questions on that? So finance sort of went through just how this all sort of plays in together. So you have some main functions from a high-level finance overview. You have your budget, your capital, and then your financial planning. So all of this you really have to drive off of your strategies. So you want to make sure that your organization has defined the strategies for your next year, 3 years, 5 years, however you may choose to look at that. And then you are doing your plan 3 years, 5 years. So we do a 5-year plan that says, here's all of our strategies. Here are market expectations. So are you going to have population growth, or people moving out of your area, or people coming into your area? What's the age of the people in your area? What services do you think they're going to need over the next 5 years? What services are growing or declining? What does that utilization look like? How do you think payers are going to shift? So how many people are maybe moving away from traditional Medicare and going to a managed Medicare product? And how does that impact your reimbursement? Or, do you see shifts in commercial? And so you're really forecasting all of that out to see what does that sort of look like for your organization over that 5-year time period. And then you're using that, and that's sort of intertwined with your annual budget. So once you have your forecast, you usually use that to set your EBITDA targets for your budget. So every facility or entity will have a target that they need to meet financially that they put into their budget, but then that may get trued up a little bit. So your budget is always feeding your forecast, but then your forecast is feeding your next year budget. So then with that, you want to have a good alignment on your capital structure. Make sure that the capital that you're spending is in line with your strategies over the next 1 to 5 years, and then sort of managing that capital, so they're all a little bit intertwined. So this is sort of another graph that just shows that planning process and how that sort of starts with your integrated planning, and then allocating capital and your budget. But then your capital is going to go back in. You're going to set a capital budget, which will feed back into your operating budget, and then you're managing that over the next year on both your capital and your operating expenses. So from a capital standpoint, this is sort of a best practice slide, but you typically have 3 different capital pools. You have threshold capital. What that means is you set a budget each year, so you have a set dollar amount, and everybody tells you these are strategic projects, or these are regulatory, or these are things that we have to do, and submit those for consideration to get funds. So then you go through a ranking process, and you always get more requests than you have money for. So you have to tell a lot of people no, and then make decisions. And again, that's why it's so important to align those with your strategies, to make sure that you're planning to spend your money on your strategies for those coming years. And then non-threshold pools, so this just covers a lot of those smaller dollar amount requests that you have, and then contingency, so you typically reserve a certain amount of your capital each year for emergency or things that come up, so unanticipated, that you have to fix immediately. How much capital do you have available? You sort of have to use your budget and your 5-year plan forecast to set that. So you want to look at your sources and your uses of cash. So how much money do you have coming in? Are you going to issue any bonds, or have any finance proceeds coming in? If you have any existing bond-related funds, any cash reserves, working capital release, and then what are you going to use that for? So how much money do you need to fund your annual operations? And then what do you have principal payments? So if you have any bonds, how much of those bonds are you obligated to pay next year? Do you want to set any aside, or do you want to increase your working capital, or just build up cash for a year? Or maybe you have plans to reduce or pay off a bond early. Then how much funds do you need to save over what time period to be able to pay your bonds off early? And once you get all of these set, then for a not-for-profit, everything that's left would be what you would spend for capital. So all of your earnings go back and invest back into the organization. And this is just an example of our budget calendar and sort of how we do all of that. So we start in January by gathering those global assumptions, market share data, a lot of the information that strategic planning provides. And then we also kick off our capital budget process in January. Just high level, start gathering from all your business leaders within the organization what capital needs that they're going to have. And then we set the 5-year plan. So we used all the global assumption information that we received in January to create a 5-year plan to set our EBITDA targets and global assumptions that we're going to put into the budget. So we set from there how much we anticipate inpatient utilization may increase or decrease. What targets do we have for length of stay is a big one. Or do we have any initiatives around anything that we may want to implement that's going to be very high level we want to put in the budget. So all this is going on. We're getting the capital request. We align those with our strategic planning timelines. So they submit all their capital projects before they have a strategic retreat where all of the executives sort of get together and they have a day. They do it on a Saturday where they spend the day working through and really defining out all their ideas for initiatives and then which ones are the best ones that they need to focus on for their community. So then we review all of those capital needs with the executives and make the decisions for the system as a whole, which projects we're going to fund, communicate those back out to the leadership within the hospitals, and they get that information as they're working on their budget. So then they know what projects that they get to move forward with the next year, so they know what they need to put in their budget, and maybe a project gets declined that they don't want to put that in their budget for those initiatives. And so all that continues, and then we true up a lot of the stuff in the budget with just allocations, depreciation, and different things you all probably don't care about. Very accounting type functions, but typically like corporate gets allocated out. So corporate is considered gets allocated out to each facility from an expense standpoint. So they get a portion of that. So their EBITDA targets are also set based off of the overhead that they get allocated as their corporate is supporting those hospitals. And then we start doing projections of our FY17 this year, but we do projections on where we think we're going to land for this year, starting at the end of this. But we do that usually all the time. We do mid-month projections every month where the CFOs, we put some information together on at the mid-month at what revenue or what services have been provided, and then they project out what they think they're going to hit where they're going to end the month financially. So we do projections quite often, 5 years, 1 month, 1 year. Anyone have any questions on that?
Does it work? You follow it? Does it work? Like,
Yes. Does it work? Do we meet our deadlines or do we follow?
yeah.
Yes and no. We usually meet all the deadlines until the end, wrapping budgets up. And so we have to have all of these presentations ready. So all of this information gets presented to the company's board. So it's sort of based on when that ends up getting set. So when that meeting is, I wish we didn't, but I found we typically will keep budgets and sort of information will trickle in a lot slower if you report out at a later period than earlier. And then some organizations don't do budgets at all. They do rolling forecasts. So they may just forecast every 3 months based off of the most recent 12 months and then do that. Every quarter do that. And then whatever time period their traditional budget would have been, they'll just take that rolling forecast that they created in that one quarter and that will be their budget, but they'll always do those rolling forecasts. So just wanted to talk a little bit about labor management. So with everything that we've discussed on revenue, decreases in reimbursement, higher Medicare population, one of the big things that you have to focus on in healthcare as an administrator is cost reduction. Labor is, like I said earlier, about 50% of a healthcare organization's total cost. So it's always a big focus to make sure that you're managing your labor pool accurately all day, every day. If you're not focusing on this, it can quickly increase before you know it. So we have a process that we use to do labor management that really focuses on standard work. So every manager has standard work on how to handle labor, and then just a lot of transparency with that. And there's a lot of visuals, so we have a whole tool just for labor management. And really looked at a proactive approach. So what a lot of people have done in the past is your financials close, it's the end of the month, you know, it takes you a week to do all of the accounting. You get the report and it's like, oh, I was over budget in labor. Well, at this point, you're already 1 to 2 weeks into the next month. So you've just wasted a significant amount of time before you knew you ever even had an issue. So what we do is we look at every single day, and we're out there coaching the analyst, and then we have a labor management team that's coaching the managers on how to appropriately schedule people on their unit every day, month, and then how to fill gaps. So we have a predictive modeling tool that's about 99% accurate 30 days out that will tell every nursing department how many people, how many patients that they're projected to have every day for the next 30 days. So they know what their census is going to be. And so they schedule based off of their projected census. And it's all based off of their staffing plans. So they build a model that the manager says, for every 5 patients, I need this many nurses, I need a shift leader, I need this many LPNs, I need a clerical. For this many patients, I need this. So that tool takes that census that's predicted and bumps it up against their plan on what they need for staffing so that they can very easily see that in 14 days from now, I'm projecting that I need 10 nurses here or that I need 7 nurses here, so they know exactly how many people to schedule for that day. So when they're doing their staffing plans, we try to work with them on nursing, what's your ratio? So are you ICU, intensive care unit, or are you a progressive care unit? So what's the acuity of your patients and how do you have to staff to that? So based off of the acuity of the patients, you may have 2 patients to 1 nurse or 4 patients to 1 nurse. Ancillary, so consider your volume fluctuation. So we know every day that the ED is going to have a spike in volume in the evening when all your physician practice and urgent care closes. There's nowhere else for anybody to go to, so you have higher ED volumes in the evening. And then how does day shift differ from night shift? So, you know, what services do you provide in the day? Maybe at night, you try not to go into patient rooms as much because you want to let them sleep as much as they can. So maybe you don't need as many nurses there. Or, you know, what's your discharge and admission? So if you are a unit that is flipping through patients, so you have a low length of stay and people are there 2 days versus a unit that patients stay on average 10 days, then you're going to need more nurses there to do all your admission and your discharge paperwork. You're going to need to align with the the diet or the housing. I'm losing it. With your cleaning team so that their housekeeping is coming in and cleaning and sterilizing things more frequently. And then physical layout. So this is one where I've seen, you know, sometimes hospitals are just bad designed. So I know we have a hospital that has 5-bed pods with a 6-to-1 nursing ratio. So it makes it really difficult for one nurse to actually see 6 patients because they have a pod of 5 and then they have to go way over somewhere completely different to see the 6 patients. So it just doesn't ever really end up working out like that. So you have to take that, the physical layout of your area into consideration and where you have supplies. So where are your clean hold rooms and how quickly can you get to your supplies, or maybe you only have one closet that's completely on the other side of your unit that the nurses are having to go back and forth a lot more often. So you set this based off of your budget, and then we look at, and it shows you in your staffing plan, once you fill it out, where you would meet budget and where you don't. And so we're not saying here you have to meet budget. You don't want to basically fake this to say, I'm going to meet budget on this, but I'm never actually going to follow this. Because what comes really useful here is when you're doing bed placement, you may have 2 units in bigger hospitals that can see the same patient population, and maybe one of them is meeting their productivity, and the other one is in one of these red areas where they're not being productive from a labor standpoint. So knowing that information, your house supervisors can place the patient in a bed on the unit that can see that patient without bringing in an extra nurse, so everybody is productive. And then I'll just put this in here just about other functions. So we went through the revenue cycle, we went through finance. Other finance accounting functions, we have our corporate financial team, which is our accounting staff. They do payroll, they do accounts payable, and then do general ledger. And then reimbursement. So there's about 25 team members in reimbursement. They work with all of Medicare financial regulations. They complete the cost reports and do a lot of work with Medicare when they come in and do audits. And tax, so not-for-profits still have to file tax forms. So we have a small department that does all of the tax and IRS forms, community benefit forms that we have to fill out. And so we have physician, a CFO over the physician side, a CFO over market operations. Our structure, hospitals are defined into markets, and each market has a CFO and their own finance team. So there's a couple of financial analysts that are housed within each hospital that meet with the managers and work very closely with operations. And then we have finance staff at corporate that works more closely with the executives and then does a lot of the administrative processes with the capital, the budget, and target plan. Anyone have any questions? Anything I didn't address that you all are just dying to know about?
So are you, with the repeal of this year, so what do you think will happen to most of all these payments mechanisms?
With the ACA?
Yeah, if the ACA is repealed, definitely everything has to change.
Yeah, I don't think that they're going to repeal it without replacing it. But I think that they came out and said they couldn't make a decision, so they're just going to drop it for now and maybe talk about it later.
They just keep going back and forth.
They keep going back and
yeah.
forth, so it's hard to keep up with every day. But I don't personally think that they're going to repeal it without replacing it with something.
It does seem like it changes day to day. Like
Yeah.
there's some new update or something new that comes out. So it's hard to keep up with.
But from an overall payment structure, I think, most definitely we're going to see more and more things go towards quality, gain sharing. We're going to know that at some point, maybe complete population health, where you just get paid a certain amount per month per person, and you figure out how to manage them.
All right, guys. Well, let's thank
Thank
glad to have you. This little gift
Oh,
for you
thank
for coming
you.
to present for us. Guys, just remember the assignment that's associated with this. I think it's your normal due date, 11:59 on Sunday, to go along with this, and the details are in the syllabus.
Is this
but-
is the video on?
Yeah, so I'm hoping that it recorded because as I was sitting back there watching, sometimes it would blink with the microphone that was marked out, and sometimes the bar would be there. So I don't really know what happened, but there's a lot of information on the slide that should be enough to help you. And you know, I know you guys take notes and stuff that should help you, and I think it's just a one pager anyway, so nothing too in depth, but. Again, I'm sure if you guys have any questions, they're free to contact, and I can, if you're okay, share your contact information. And yeah, thank you again for coming. Appreciate it, guys. Appreciate you know, working with me this semester, and enjoyed having you in class. And good luck on whatever future direction you're heading for. Other than the one pager that kind of goes with this, I think the last thing we have is the exam. So. Which is next week, right? So yeah, week before finals. So I'll be out of the office starting noon tomorrow through Friday. I'll be at a conference. So if you have anything, just shoot me an email or stop by my office before then. And then, you know, next week you're always welcome to stop in. So that's all I have, guys. So thank you so much.
Thank you.
I need to ruin your hopes, but normally like flashes green when people are talking.
Yeah,
And it has not done that once.
yeah, I've
Someone
noticed.
talking.
No,
Was it
it's